Hi there, Dr. Mahipal. I'm very interested in hearing more about your paper that you published not long ago. This was published in Cancers, Outcomes of Patients with Advanced Hepatocellular Carcinoma Receiving Lenvatinib Following Immunotherapy, a Real-World Evidence Study. And I think it's this topic that is very clinically relevant in the modern age. And as you acknowledge in the paper, while the TKIs, sorafenib, and lenvatinib play an important role in liver cancer, historically that was a frontline role for advanced patients. With the movement of immunotherapy-based combinations, such as atezobev or durvalumab, now in the frontline setting, a lot of the data we had before that supported the approvals of drugs like lenvatinib. The challenge is, how do we incorporate that into the modern age, right? And obviously the REFLECT study, the pivotal study for lenvatinib, was done versus sorafenib prior to the use of IO in frontline. And I think all of us are looking for data to support the continued use of these drugs in the modern era of liver cancer management. So could you give us some background about the study and how you perceived answering this question?
Sure. Hello, Dr. Fenn. Thanks for having me on this interview. So as you mentioned, right, so the treatment landscape for hepatocellular cancer has changed a lot in the last few years. And frankly, thanks to some of our efforts from you who had done the clinical trials, the pivotal clinical trials, which has changed the management. We used to have tyrosine kinase inhibitor as a first-line treatment and second-line treatment, frankly speaking. And now in the modern era where immunotherapy has moved on to the first-line treatment, whether it's atezobev or durvalumab or some other combination, we don't know how the TKI or patients on tyrosine kinase inhibitors would respond after they have received immunotherapy. And we all, based on previous data or experience, we use in the second-line setting different tyrosine kinase inhibitors, typically lenvatinib or sorafenib, but some other like cabozantinib, regorafenib, etc., are used as well. So in this study, we thought like one of the more common regimen used is lenvatinib after progression on immunotherapy is if we look at some real-world study in looking at outcomes for the patient who received lenvatinib after progressing on immunotherapy. As mentioned before, there's no clinical trial data, but it's routinely done in clinical practice. Like, what does that mean? Does it hold up? Or the outcomes are not as good or are as good? We also know some of the outcomes with tyrosine kinase inhibitor, both in first and second line, but we really have no idea how they would respond after someone has progressed on immunotherapy. Is it a fast progression or slow progression and so on? Expanding on this trial, so we looked at it at Mayo Clinic at all our 3 sites, including Minnesota, Arizona, and Florida, looking at how many patients had received lenvatinib after progressing on immunotherapy. And we found about 53 patients. Just to keep that in mind, that they're not all purely second line, but more than 85% of our patients were second line who received lenvatinib as a second line option. So there were some patients who had received 2 or 3 lines and then subsequently received lenvatinib. But more or less, most of our patient population were second line lenvatinib after progressing on immunotherapy. And what we found that median PFS was about 3.7 months and median OS was about 12.8 months. And if we restrict the patients to just Child-Pugh A, so as you know, this is a mixed picture because the real world study retrospective, there were patients with Child-Pugh A and B and rarely with C. So if you just look at Child-Pugh A, the median survival was about 14 months compared to 12.8 months in the whole population, and 5.2 months was the median PFS compared to 3.7 months for the whole population. So a little bit higher in Child-Pugh A as we would expect. So this actually kind of confirms our findings, right? Like we kind of expectations, at least on the median survival, was pretty reflective of our patient population. And it was consistent with actually in the REFLECT trial as well, which was a first-line trial of lenvatinib, where the median OS was around 13.6 months and median PFS was 7.4 months. One of the caveat I would again say it's a real-world study, but it's in a very broad tertiary care center where we a lot of get secondary referrals. So the patient population might be a little bit different than when we do a randomized phase 3 clinical trial. So just to keep that in mind.
Well, it's also real world evidence, right? Which differs from a phase 3 study, which is, controlled with monitoring and, definitive times of imaging, right? I think the survival data is not subjective, right? PFS, obviously depending on the data, when patients got imaged, what frequency. I mean, the PFS was based on what the physician called in the chart review, or was the imaging centrally reviewed? Because I also noticed you had a pretty good objective response rate as well.
Yeah, I absolutely agree with you. So all the PFS and objective response rate could somewhat be subjective to who the reader is. At least for the objective response rate, we actually have our own internal review, so it was consistent what we did. The problem with PFS was the PFS is obviously the scans are typically we do it every 2 months, but based on the patient condition, it could be 2 months, it could be 3 months, 4 months, and toxicities. So there's always that caveat if the PFS is very, very consistent as compared to a randomized controlled trial. That I totally agree with you.